Hello, and welcome to this presentation, Applying Advances in PET Imaging to Facilitate the Early Diagnosis of Alzheimer's Disease. Our goal is to prepare nuclear medicine physicians and radiologists for new diagnostic workflows. I'm John McConathy. I'm a nuclear medicine physician and radiologist. I'm the Director of Molecular Imaging and Therapeutics at the University of Alabama at Birmingham, and I also serve as the imaging core leader for our Alzheimer's Disease Research Center. I'd like to introduce our panelists, Gil Rabinovici and myself, John McConathy. I'd like to thank PeerView for providing the session and Lilly for providing the educational grant enabling the symposium. And as a reminder, for additional follow-up polling during the presentation and submit your questions into the chat box and we'll answer them during the presentation. Here's the link to the website, peerview.com/ad-pet24. You can view the slides and practice aids now and download them after the workshop.
Hi, my name is Gil Rabinovici. I'm a professor of neurology and radiology at the University of California, San Francisco, and it's my pleasure to welcome you to this session. This is a really important time for radiologists and nuclear medicine physicians to be aware of the rising demand for PET imaging in Alzheimer's disease. Alzheimer's disease, as we'll discuss, is an incredibly common disease as our population ages. And the field in the last few years has really entered a new era of molecular diagnostics and disease-modifying therapies with antibodies that target amyloid plaques, recently receiving approval by the FDA. Also in October of 2023, Medicare lifted a 10-year national no coverage decision on reimbursement of amyloid PET scans, leading the coverage decisions to the local Medicare administrative contractors. But theoretically, at least, amyloid PET should be a covered service for most Medicare beneficiaries. And as Dr. McConathy will discuss, tau PET ligands, at least one approved by the FDA for clinical use, may also play a growing role in AD diagnostics and therapies. And so our goals for today's session are really to improve your understanding about the role and importance of PET imaging in facilitating a timely and accurate diagnosis of AD in this new era, and also to equip you with the information you need to integrate amyloid and tau PET tracers into your clinical workflows to improve the early detection and diagnosis of AD and the outcomes for our patients. So I'll start with some background information on why this is really an exciting time and an important time to get serious about improving the early detection and diagnosis of Alzheimer's. Alzheimer's disease is the most common cause of dementia. It's thought to contribute to 60 to 80% of all cases of dementia. Alzheimer's disease is really a public health emergency. It affects 1 in 9 people age 65 and older. Currently, it's estimated that about 7 million Americans are living with Alzheimer's disease, and that number is expected to more than double by 2060. And as you can see, that increase in prevalence is really driven by that 85 plus group, by an aging population. So there is a real public health need to identify better therapies. There are many studies that describe the benefits of early detection of Alzheimer's disease for patients and families who are going to memory care centers seeking an explanation. They're really looking for a specific diagnosis, even if it's bad news, even if it is a diagnosis of Alzheimer's. That does provide some validation and ability to move on with next steps in care planning. An early diagnosis really enables patients to participate in their own care planning while they're still capable. It empowers them to make lifestyle changes that have been shown to potentially slow the progression of the disease, manage comorbidities like vascular risk factors that can contribute to cognitive impairment. It really facilitates access to education and support services that are available. And in this new era, a specific biomarker-supported diagnosis is required for treatment with recently approved and potentially emerging new disease-modifying therapies. And there is growing opportunities to participate in clinical trials, but these trials, by and large, will be focused on early stages of the disease. We now recognize that Alzheimer's disease takes place over decades in terms of the clinical evolution. There is a long preclinical phase that lasts 10 or 15 years. In stage 1, patients are completely asymptomatic. They don't have any memory symptoms, but may have biomarker evidence of plaques or tangles, the molecular pathologies that define the disease. In stage 2, also known as subjective cognitive decline, patients or families may notice a change from a previous baseline, and yet, when faced with objective memory tests, patients may still perform in the normal range and remain independent with their daily functions. Stage 3 is also referred to as mild cognitive impairment or MCI. At this stage, patients have a decline in their cognition that can be confirmed with objective neuropsychological testing, but patients are still able to function by and large independently. And then stages 4 to 6 represent mild, moderate, and severe stages of dementia, respectively, with progressive impairment now, initially in higher order, more complex activities of daily living, like managing finances. And ultimately, at stage 6, the severe dementia stage, patients are fully dependent with most activities of daily living. Alzheimer's disease neuropathologically is defined by the accumulation of toxic protein deposits called plaques and tangles. The plaques are extracellular deposits that are composed largely of aggregated forms of the amyloid beta polypeptide. And for the last 10 or 15 years, we've been able to image these and quantify them in living people using PET ligands that bind very specifically to fibrillar plaques using amyloid PET scans. Intraneuronal neurofibrillary tangles are composed of aggregated forms of hyperphosphorylated tau protein. And for the last 10 years or so, we have had a number of PET ligands, including one FDA-approved ligand that can detect and quantify these tangles in living patients. It's really the combination of plaques and tangles that defines the disease neuropathologically. And with PET imaging and other biomarkers, we can now detect these proteinopathies in living people. Really, right now, this is breaking news. There are revised criteria for Alzheimer's disease that are very much rely on biomarkers to define and detect the disease. This includes fluid biomarkers that can be measured in cerebrospinal fluid or plasma, as well as imaging biomarkers. And these are divided into core 1 biomarkers that really detect the earliest stages of Alzheimer's disease that are detectable in vivo. A core 1 biomarker, such as amyloid PET, which measures the amyloid beta proteinopathy, is sufficient for a diagnosis of Alzheimer's disease. In the clinic, this can also be done using ratios of specific proteins in the cerebrospinal fluid, as highlighted on the left. Core 2 biomarkers develop later than core 1 biomarkers. They're more closely tied to the onset of neurodegeneration and clinical symptoms. And from an imaging perspective, tau PET, which measures the AD tau proteinopathy, is the core 2 biomarker that we use in radiology and nuclear medicine. The combination of core 1 and core 2 biomarkers can really be used to stage biological disease severity. The combination provides a lot of information to the clinician about whether clinical symptoms are associated with AD pathology. It can inform the risk of clinical progression in people in the preclinical stage, and also rate the likelihood of clinical progression in people who are already symptomatic, as we'll hear from Dr. McConathy. The new AD criteria provide biological staging of disease using amyloid and tau PET. In stage 1, patients show elevated amyloid on PET imaging, but don't yet show evidence of tau proteinopathy on tau PET imaging. In stage B, tau PET signal starts to appear in the medial temporal region. In stage C, tau PET can be seen in the neocortex to moderate amounts of uptake. And finally, in stage D, the most advanced stage, there's high neocortical uptake of tau PET. And again, the spread and intensity of tau PET binding can be informative in terms of prognosis and potentially in terms of likelihood of responding to therapies. Now, even though amyloid PET has been FDA approved for clinical use since 2012, patient access has been really limited for many years, in large part due to lack of reimbursement by Medicare and other third-party payers. In 2016, a group of investigators, including myself, partnered with Medicare to perform a study called the Imaging Dementia Evidence for Amyloid Scanning, or IDEAS study. This was a national single-arm multi-site longitudinal study that was used to evaluate the clinical utility of amyloid PET in Medicare beneficiaries who had mild cognitive impairment or dementia and had published appropriate use criteria for amyloid PET. Essentially, these were people who already had cognitive impairment. The clinician was considering Alzheimer's disease, but wasn't sure if Alzheimer's was the cause of impairment. And the clinician thought that that learning about amyloid PET status would help guide diagnosis and management. In this study, we enrolled over 18,000 patients across the US over 2 years. This map shows the really national network of clinical sites and PET facilities that were involved in the study. In total, almost 600 memory clinics and 350 PET facilities. And to summarize a lot of work in one slide, we helped identify that amyloid PET can be very useful in guiding patient management. We saw changes between the pre-PET and post-PET management plan in over 60% of patients with MCI or dementia. This included changes in the prescription of drugs specific for treatment of Alzheimer's disease, like cholinesterase inhibitors or memantine, changes in the use of drugs that are used to treat other causes of dementia or dementia risk factors, and changes in how patients are guided about safety and future planning. Our goal in this study was to see a change in management in at least 30%, and the effect we found was more than double that. We also saw quite frequent changes in diagnosis following amyloid PET. In 25%, the diagnosis changed from AD to a non-AD condition based on a negative PET scan, and in another 10.5%, the diagnosis changed from a non-AD to AD cause of dementia in the setting of a positive PET scan. Based especially on the management and diagnosis data, as well as the availability of new therapies, CMS retired their national non-coverage decision in October of 2023, and amyloid PET should now be a covered service for most Medicare beneficiaries. Hopefully, private insurance will follow in turn as well. Amyloid PET has really been instrumental in helping the development of a novel class of therapies for Alzheimer's disease that modify the biology of the disease. These are monoclonal antibodies that target and remove amyloid beta from the brain. The first drug to receive FDA approval in June of 2021 was an antibody named aducanumab. The FDA granted accelerated approval for this drug based on a very clear signal that the drug was removing plaques from the brain on PET scans. But this decision was controversial because the clinical benefit was less evident from 2 phase 3 studies that were completed. And in fact, this drug was ultimately pulled from the market in January of 2024 based on limited clinical uptake and reimbursement. Lecanemab is another antibody that targets amyloid plaques. This has had a smoother ride into the clinic with accelerated approval based on phase 2 data in January of 2023 and full traditional FDA approval in July of 2023 based on a clear clinical benefit demonstrated in a phase 3 study. Donanemab is a third antibody that is currently being reviewed by an FDA advisory committee, and as we'll discuss, this drug also showed a clinical benefit in a placebo-controlled randomized clinical phase 3 trial. These graphs show changes in amyloid PET for lecanemab, aducanumab, and donanemab in the phase 3 studies. But you can see that the placebo arms show stable to maybe slight increases in the amyloid PET signal over 18 months, whereas patients that are treated with the drug are showing a progressive reduction in amyloid plaques. In the donanemab phase 3, for example, over 75% of patients had completely cleared plaques based on a PET scan at 76 weeks. Importantly, for at least 2 of these drugs, reduction in amyloid plaques was also accompanied by a slowing of clinical decline. The graph here shows data from the phase 3 lecanemab study, showing changes in a clinical scale called the Clinical Dementia Rating Sum of Boxes, or CDR-SB. This is an 18-point scale that measures very important patient-oriented outcomes like changes in cognition and function. Declines on the y-axis represent disease progression, but you can see that in this study at 18 months, patients who were treated with placebo declined more on this scale than patients treated with lecanemab. Overall, on average, there was about a 27% slowing of clinical decline based on patients being treated with an anti-amyloid antibody. And this was the first clear evidence that amyloid removal can translate into a clinical benefit in early stages of Alzheimer's disease. These are data from the donanemab phase 3 study. This study had some innovations that are important to discuss. Donanemab, like lecanemab, is also an antibody that donanemab targets an epitope that's present on more mature plaques. In this study, patients were stratified based on their tau PET uptake. If there was no evidence of tau PET uptake, they were actually excluded from the trial. And then about two-thirds of the patients showed low to medium neocortical tau. Their clinical outcomes were examined separately from a total population, which also included about 30% of patients who showed high tau uptake at baseline. The hypothesis here was really that the earlier you treat, the more effective the therapy, that patients in the low to medium tau group would have a greater benefit from amyloid removal. Another innovation in this trial is that the antibody treatment was actually titrated based on the amyloid PET response. And patients on active treatment were switched to placebo when their amyloid PET scan turned from positive to negative. Here you see some data from the phase 3 study. On the left, you can see amyloid clearance on PET in drug compared to placebo. In the middle panel, you see changes in a fluid biomarker called plasma phosphorylated tau 217. This marker measures amyloid-induced changes in tau phosphorylation and secretion. And for the first time, you can see that treating a patient with an anti-amyloid drug can actually change the biology of tau pathology, which is really important in terms of modifying the progression of disease. And then importantly, here we see the slowing of cognitive decline. In this case, in the low to medium tau group, there was about a 36% slowing of cognitive decline in patients treated with drug versus placebo. That effect was lessened, however, in patients who entered the trial with high tau PET uptake. So again, the earlier you treat, both clinically but also biologically in terms of tau progression, the more clinical benefit these patients are deriving from amyloid removal. Medicare is covering the fully FDA-approved drugs, but they do require that patients be included in a registry to monitor the long-term benefits and also safety concerns associated with this novel class of therapies. One Medicare-approved registry is ALZNet, which is led by the Alzheimer's Association. This is a registry that is acquiring longitudinal cognitive, functional, safety, imaging, and biomarker data from people treated with novel FDA-approved AD therapies in the real world. And these codes indicate ways to access a lot of the educational materials in terms of PET and MRI, Medicare and billing information, and also for sites that are interested in participating in ALZNet, how to register and become an ALZNet site. So I hope that many of you who are watching this and are providing therapy will take advantage of the many resources this network provides. I'd like to shift gears now and discuss a couple of clinical cases with my colleague, Dr. McConathy. I'll start with a patient from my practice. This was a 78-year-old woman who presented with about 18 months of progressive cognitive complaints. Her main complaints related to memory loss. She was misplacing objects more frequently, had some difficulty recalling recent events, conversations that she'd had, twice left the stove burner on in the kitchen. She also complained of some difficulty with word retrieval, a little more trouble navigating in new environments. She had more difficulty processing complex information, planning and multitasking, noted some decrease in her ability to concentrate. In terms of psychiatric features, she endorsed some irritability, but didn't really have any depression or anxiety. She was retired and fully independent in terms of her activities of daily living. Her past medical history was notable for breast cancer, previously treated with lumpectomy, radiation, and tamoxifen, in remission since 2006, dyslipidemia and vitamin B12 deficiency, and her only medications were simvastatin, B12, calcium, and vitamin D supplementation. Her family history was notable for Alzheimer's disease or dementia in her father, which developed in his early 60s, her mother at an older age in her early 90s, and a brother in his 70s. She was a retired social worker who had 22 years of formal education. She drinks 1 glass of wine daily and endorsed some remote tobacco use. So, on general physical exam, she was a little bit hypertensive. Her pulse and BMI were normal. On neurological exam, she showed just what I call micro findings. So, a little bit of slowing in her finger and foot tapping, a little bit of decreased sensation in her feet, an absent Achilles reflex, and a positive Romberg sign. These latter are probably indicative of peripheral neuropathy related to vitamin B12 deficiency, but no Parkinsonism or motor findings on her exam. On cognitive testing, she did quite well. Her mini mental was 30 out of 30. She actually scored in the normal range on verbal memory tasks. Her visual memory performance was 1 standard deviation below mean for age, so maybe low compared to her previous baseline, but within the normal range for age. And she performed completely in the normal range on tests of language, visuospatial, and executive functions. This is her brain MRI scan shown in neurologic orientation. These are axial flare images. You can see that the MRI is pretty unremarkable for age. There may be a little bit of medial temporal atrophy on the right, but I would say not outside the normal range for a 78-year-old, and maybe some prominent sulci in the posterior parts of the brain, but nothing that's really easy to call as abnormal for age. And similarly, some evidence of white matter hyperintensities in the periventricular and subcortical regions, but difficult to call this abnormal for age. And so, with the MRI and cognitive testing complete, this completes our standard of care in terms of evaluating someone with cognitive decline. And so, with this information, we're going to shift to a polling question. So, based on the information you have so far, what is this patient's most likely diagnosis? Please take a minute to answer this question. So in this case, I think my answer would be a diagnosis is unclear and need more information. I'm a little bit on the fence between whether this is normal age-related cognitive decline. I think arguing for that is the fact that the patient is actually scoring pretty well on neuropsychological testing, not outside the normal range. But I'm really worried actually because the patient endorses a clear change from their previous baseline. Some of the symptoms they describe, like misplacing personal items, that can happen just as part of normal aging. But forgetting recent events, forgetting the burner on the stove more than a few times makes me worry. And then uh, also the family history makes me worry. We do know that people who have a family history and first degree relatives are at about 2 or 3 times higher risk compared to people who don't have a first degree relative with Alzheimer's. And that certainly helps me or makes me more concerned about some of these complaints in light of the family history. So, based on the data that we have now, I would lean a little bit towards maybe this is early mild cognitive impairment. The visual memory score is a little low compared to the other scores and compared to the patient's background and education. That said, we don't have strong objective evidence and to labels this person as having Alzheimer's disease based on the subtle changes that we're seeing so far, both on cognitive testing and MRI, would be an overreach. And so to me, this case really demonstrates the need for more definitive testing, biomarker testing, to be able to answer the question that the patient comes in asking me, which is this normal aging or is it Alzheimer's disease? And I think using the current tools without PET scans, I can say, well, I'm a little worried, but I'm not sure. And, that's a pretty unsatisfying answer for a patient who's trying to plan their future. I don't know, John, if you had any additional comments on this case.
Yeah. So one thing I would be interested in knowing from your perspective, I obviously come from an imaging point of view, but in these cases where you might not even quite qualify this person as mild cognitive impairment, currently we kind of think of using amyloid PET in people who have MCI or evidence or dementia, and kind of what's your thought and trigger in your practice for when you might refer someone to amyloid PET?
Yeah, I think at the moment, it would be mild cognitive impairment or mild dementia where Alzheimer's is on our differential, but we're not quite sure. And we do feel like the PET is going to help tip us one way or the other in terms of how we care for the patient. In this case, I'd lean towards MCI. The old criteria used to have very strict cutoffs in terms of memory performance, like you had to be 1.5
Yeah.
standard deviations below the mean. I think the newer criteria and the criteria that I think of as a clinician are more the gestalt of the entire presentation. The story is pretty concerning for MCI. There is, a decline that the patient endorses. Their spouse actually had the similar concerns. The family history was pretty suggestive, and the visual memory test score did stand out in an area that she is complaining about as lower than many of the other scores. And so, maybe she's one standard deviation below mean right now, but if we had tested her 3 or 4 years ago, maybe she would have been, at mean or higher than mean based on her other testing. And
Vision.
so, the medial temporal lobe on the right is maybe a little bit atrophied, and that fits with the visual memory. So putting it all together, I would probably call this MCI, and I would proceed with PET scans in this case.
Thanks, Gil. So this is a second different patient. This is a 63-year-old man who presented with 1 to 2 years of progressive forgetfulness and difficulty with word finding. In terms of notable history, he was a former pilot in the military, and he'd ejected from a plane which subsequently crashed about 30 years ago and did have an injury related to that. He has had treatment long-term for anxiety and depression, and not a lot notable in his family history. There was late life memory loss in his father, although a formal diagnosis was never made. And, he showed a little bit of diminished score on the ABC dementia scale with a 26 out of 30, as well as a general activities of daily living score of 24 or 26. So maybe a little bit of evidence of impairment, but not very remarkable. He had a non-contrast brain MRI performed, which is, part of the standard workup in patients with memory problems or complaints. And here the main finding is on the flare, we see a hyperintensity in the right frontal lobe where there's some encephalomalacia, which is most likely related to his prior trauma. There is some global atrophy, but this is fairly nonspecific and doesn't really lend itself to a diagnosis. And looking ahead to potential therapy, we do not see microhemorrhages on the blood sensitive sequences in the right column. So for this patient, we're going to also ask a polling question. So this is a 63-year-old man with mild cognitive impairment who presents for the diagnosis of the cause of this impairment. His non-contrast brain MRI showed right frontal encephalomalacia consistent with his prior trauma, as well as moderate global atrophy and no microhemorrhages. And based on what's been presented so far, what would you choose as his most likely diagnosis? So in this case, I think the answer is diagnosis is unclear. This could be the beginning of Alzheimer's disease or another neurodegenerative disease, but we have a single time point, and none of the testing or information I've provided so far provides a clear diagnosis. I think chronic traumatic encephalopathy is not a good choice, as he's had this injury a long time ago. His symptom onset is relatively recent. So while not impossible, not a likely choice. And Alzheimer's disease and frontotemporal dementia, we really don't have enough information to make either of these diagnoses clinically. And while mood disorder is definitely a consideration, particularly depression, we don't have information that goes with a mood disorder in this patient, although that is something that should also be considered.
Yeah, I agree with that, Jonathan. I might just add that looking back on his MRI scan, there it is. I'm pretty concerned that this is a neurodegenerative condition. I think for age 63, there's a lot of ventriculomegaly, sulcal prominence in the medial temporal lobes and the neocortex, especially in more posterior areas. And so, um, I think that would put mood disorder or something like that lower on my differential. Um, I think that the structural imaging argues a little bit for Alzheimer's disease based on the more posterior neocortical pattern of atrophy. It would not be
Hmm.
consistent, in my opinion, with frontotemporal dementia, where you tend to see a lot of frontal and anterior temporal involvement, but sparing of these posterior areas, which do seem to be affected. So, um, I think this case also really nicely highlights the fact that um, most cognitive impairment is multifactorial, even if there is one primary disease driving it. And so you wonder if, the prior traumatic brain injury and the encephalomalacia might have reduced a little bit his so called brain reserve, his ability to tolerate other pathologies that are coming and compensate. For example, if he is in early stages of Alzheimer's disease, those frontal areas might be less able to compensate and come up with alternative strategies to compensate for decline in other brain areas. So I think this really nicely highlights some important points that are really relevant to real world patient care.
Yeah, Gil, no, thanks. I agree. And, I do, while we're not going to get into this topic very much, I think, the idea of comorbidities and multifactorial causes of dementia, even in people with the diagnosis of Alzheimer's disease, is another area that's going to be important to understand, particularly in terms of how people respond to therapies. If they have a single cause, they may do better than people who have multifactorial causes. In this section, we're going to focus on improving the early recognition of Alzheimer's disease pathology with amyloid PET. So, if you're going to be interpreting amyloid PET, you need to be sure that you've completed in person or online training specific to the tracer you're using. So, here are some QR codes for the 3 approved agents for amyloid PET: florbetapir, florbetaben, and flutometamol. And again, they have very similar approaches to reading, but there are tracer specific criteria that you should use when making your interpretation. So it's not a one size fits all approach. Uh, However, in general, the clinical read is based primarily on a qualitative interpretation of the activity in the cerebral cortex versus white matter. And the current reading criteria designate scans as positive or negative for amyloid. A negative scan corresponds to no to scarce beta amyloid neuritic plaques at pathology, whereas a positive scan corresponds to moderate to frequent beta amyloid neuritic plaques at pathology. Here are 3 different individuals with negative and positive amyloid PET scans. So patient 1 is a negative case. Patients 2 and 3 will be positive. When I read these, I start looking at the cerebellum to evaluate gray-white contrast. And in the patients we'll see in clinic for amyloid PET, there really should not be deposition of amyloid in the cerebellum. The one exception is patients with familial autosomal dominant Alzheimer's disease, which is going to be on the order of 1% or less of cases. You may see some deposition early in the disease course in the cerebellum. However, in the vast majority of cases, the cerebellum should have good gray white differentiation, which we see in all 3 of these people. As we look at axial slices more superiorly here at the level of the temporal and occipital lobes, in patient 1, we see good gray white differentiation throughout. In patient 3, we see really loss of gray white differentiation. And so, patient 3, once you've seen a few cases and done training, is simple to identify as a positive case. Patient 2 is also a clearly positive case, but here it's a little less certain. We still see some gray white contrast, but it is reduced compared to the gray white contrast in the cerebellum. And these trends or these findings remain true throughout the rest of the axial images. In some cases, it can be useful to look at images in the coronal plane where you have the cerebellum as well as the cerebral cortex in the same image. I find that useful for evaluating gray-white contrast in the cerebellum versus the cerebrum. In patient 1, you can see that the gray-white contrast is very similar in the cerebrum and cerebellum. In patient 3, good gray-white contrast in the cerebellum, but really lost throughout the cerebrum. But in patient 2, you can see that while there is some gray-white contrast between the cerebral cortex and white matter, it is not nearly as high as the contrast in the cerebellum, which makes us confident this is also a positive case. You can also evaluate the sagittal images to look at the precuneus and posterior cingulate, which are important areas in neuroimaging for Alzheimer's disease with both FDG and amyloid. So when we interpret amyloid PET results, it's important to remember that this is a biomarker for pathological amyloid deposition. And as already discussed, amyloid pathology can precede clinical findings by up to 2 decades. And just because we see Alzheimer's disease pathophysiology, that does not mean the patient has cognitive impairment or a clinical diagnosis of Alzheimer's disease dementia, but it is biomarker evidence for amyloid pathology. And so if we have a negative scan with amyloid PET, this makes it very unlikely that the patient's cognitive impairment is due to Alzheimer's disease. In terms of the clinical performance of the FDA-approved amyloid PET tracers, they are quite similar. They do differ a bit in terms of the administered activity, the timing of scanning relative to tracer injection, and the reading criteria. But in terms of their diagnostic performance, they're all quite similar. I would also like to bring up multimodality imaging in Alzheimer's disease with PET and MRI. And if you're a nuclear medicine physician, you may be quite familiar with PET, but less comfortable with MRI. And similarly, if you're a neuroradiologist, you may be quite comfortable with MRI and less with PET. But using PET and MRI together, either acquired simultaneously on a PET MRI scanner or separately acquired and fused with software is quite helpful. And in those cases, you may be able to provide a comprehensive evaluation for Alzheimer's disease in a single session, looking for the imaging biomarkers such as amyloid or tau, looking for patterns of atrophy on MRI, looking for signs of ARIA or baseline microhemorrhages on the MRI. And the MRI does have key roles in the evaluation of early Alzheimer's disease. It's used to exclude other causes like stroke, tumor, or other structural abnormalities. It can be used to establish and is needed to establish the presence of white matter disease as well as hemorrhages in terms of evaluating for ARIA-H hemorrhage or ARIA-E edema. And there's growing use of MRI-based volumes and PET region definition in routine clinical work that can make it easier to define regional brain atrophy as well as quantify PET results. So there's many tools that can be used for this. And that's a good thing because that means a lot are available, although I think there's a lot of room for standardization. Something that we are developing at our center, and there are similar approaches, are using segmentation of the patient's volumetric MRI to develop a map of brain regions, and then applying it to the original MR to confirm that they're correct with the ability to edit if needed, and then applying these regions of interest to the PET to get either dynamic or static PET values from various brain regions. Here's an example of workflow that we use at our center. So this is an example. I'm showing this as a video so you can get a real-time example of using brain segmentation to quantify PET data. So this is a segmentation map from a commercial vendor. And basically, we get a volumetric MRI, we send this to the vendor, and about 10 minutes later, we get it back. Once we return it, we then fuse it with the patient's original MRI used for the segmentation, and then apply that to the, fuse that with the PET in order to apply the regions of interest from the brain segmentation map to the PET. I don't want to pretend that we're the only ones who do this, but I want to show you how this might look in routine clinical practice and make you realize that this is something that a technologist or a physician could easily do in a routine workflow. And I think this is going to become increasingly important as we quantify um, amyloid and tau in specific brain regions, both for deciding whether therapy is appropriate as well as for deciding whether or not to stop therapy based on clearance. And you can see in this scenario, we're able to review the contours, the brain regions on the original MR as well as on the PET, which gives us confidence that the brain regions are faithfully being quantified and identified. So here's an example of using this sort of workflow in a real clinical case. So this is a patient who presented with cognitive impairment and predominant language difficulties at presentation. So here's the results of their amyloid PET, and this is a straightforward case of a clearly positive amyloid PET scan with really loss of gray-white differentiation throughout the cerebral cortex. And in fact, in some areas, maybe even a little bit of higher activity in the cortex compared to white matter. We can also use volumetric MR analysis to identify that the temporal lobe has atrophy greater than expected for sex and age. And this is isolated to the temporal lobes. And in fact, it was more severe on the left than the right, which fits with the patient's presentation with language difficulties. We can also use this to quantify SUV ratios, which in this case was done by using the segmentation applied to the PET to look at the SUV in specific cortical brain regions divided by the SUV in the entire cerebellum. Reference regions can differ depending on your approach. The entire cerebellum can be used, cerebellar gray matter can be used, white matter can be used. And those can give different cutoffs. In this case, we're using SUV ratios with the red dotted line considered positive. And as we saw on the visual assessment, these regions are well above the cutoff for positivity. And so you can see how you might use this in a routine clinical workflow to provide not only the qualitative visual assessment of the PET, but also information about areas where atrophy has occurred, as well as quantitation of the SUVR or Synoloid. Because SUVR assessment is useful, but not standardized. And that is one of the challenges in the field in terms of using quantitative amyloid PET across the country and across the world, is how to do it and how to get the same results at different centers that have different scanners using different amyloid PET tracers. There's a number of approaches. Some is regional segmentation, as in the example I showed you, which is based on the individual MRI. Or this can be warped to an atlas to give standard regions that are quantified. And this may focus on gray matter and white matter in terms of the region of the reference region. There are also you can also correct for partial volume, meaning when there's cortical atrophy and you can get partial volume averaging of your PET signal, partial volume correction is an attempt to account for that in the quantitation. The normalization region frequently is the cerebellum. It may be gray matter or gray matter plus white matter, depending on your approach, or it can also be cerebral supratentorial white matter. One of the challenges in quantitation is there is variability based on the method, and it can be as great as 30%. There's a lot of effort to make Synoloids the standard, which is basically normalizing SUVRs based on the tracer and calibrating the data to a widely used research amyloid PET tracer, PIB, in order to provide a value that then applies across institutions and across tracers. And so in that sense, an SUVR may be technique and tracer dependent, whereas a Synoloid value from the same study can be compared across centers and across tracers. This is a nice study done to look at the impact of SUVR on visual amyloid PET assessment. And this used software from a number of different vendors listed here. and included a group of autopsy verified Alzheimer's disease subjects. And in this analysis, there was some benefit. It's a little bit of a busy slide, but in the upper right corner with the red rectangle, you can see that the visual analysis alone was not quite as good as the visual analysis plus quantitative, so the day one versus day two. There was a statistically significant improvement of several percentages. If you look at the below average readers and above average readers, I try to be a little more positive and think of them as less experienced and more experienced readers. But regardless, you can see that the benefits were higher in the below average reader group. Their performance increased more than the above average readers. So there is some benefit to purely making the right call on positive or negative, although I would argue that benefit is relatively small, especially in experienced readers. Um, Again, Centiloids are a way to normalize SUVR data and allow direct comparison. And so the currently a threshold of about 25 Centiloid units is the threshold for positivity, whereas readers generally will agree once a study is 40 Centiloids or higher in terms of positivity. And in the graph, you can see in blue the visually negative nicely correspond to low Centiloids, with the range between 25 and 40 having kind of visual borderline reads and potential for disagreement between good readers. Whereas once you get about above Centiloid score of 40, you're in the red, which are visually positive with good agreement between readers. This is another example looking at the accordance between local visual reads in the IDEA study and a quantification method using a Centiloid threshold of 24.4, so a fairly low threshold. And even with that low threshold, there was good agreement in about 87% of cases, with the discordance happening primarily at the cut point. And so about 6% of cases were visually negative but considered quantitatively positive, while about 8% of cases were considered visually positive while quantitatively negative. And so, again, there may be some benefit in terms of assigning positivity and negativity to amyloid PET scans with quantitative methods, but the yield is relatively low. Visual reads do a good job in terms of positive versus negative. Um, there are limitations to amyloid imaging in terms of interpretation. And so in some patients, there's relatively low signal to noise. That's inherent to many of the amyloid PET tracers and really all of the clinically approved agents. But that can be lower in some patients than others. Because of the diffuse white matter activity, you need to be careful and make sure that the area you're looking at is gray matter versus white matter. This can be an issue if there's misregistration. If a patient is moving during the PET acquisition, this will tend to move the white matter over the gray matter during the course of acquisition. And thus, you may see positivity that's due to motion rather than true abnormal amyloid in the cortex. You also need to be careful of attenuation correction artifacts if the patient moved between acquisition of the attenuation correction map with CT or MRI and the PET acquisition. Cortical atrophy is also an issue. If the cortex is narrow and small volume, it can make it difficult to assess compared to the adjacent white matter. And then there's the inherent inter-reader variability. Different readers have slightly different thresholds, although I think, as you saw from the comparison of visual read to quantitative read, there's generally good agreement in most cases. Here's another polling question, so please take some time and answer it. So in the final section of this presentation, we're going to move from the diagnosis to prognosis of Alzheimer's disease using tau PET. There's currently one FDA-approved tau PET tracer, fluortaucipir. Here's some information about the dosage and image acquisition. And an important thing to know about reading fluortaucipir scans is that this is a semi-quantitative method where we use a two-dimensional region of interest, the cerebellum as the reference region, and then set the reading scale to a color scale that allows us to see a transition when voxels are above 1.65 times the reference region or higher. So, in terms of the diagnostic performance of fluortaucipir PET in clinical trials, it works well in patients who have more widely distributed tau pathology in the neocortex. Here, B3 is a combination of BROC5 and BROC6 neocortical regions. And in that case, there's good sensitivity and specificity across readers. Do note that when the neurofibrillary tangles and tau deposition are more restricted in limbic regions, the fluortaucipir PET may not be positive. The interpretation criteria is based on tracer uptake in neocortical gray matter. With fluortaucipir, there can be off-target binding in choroid plexus, striatum, and brainstem nuclei. So don't confuse those for tau positivity. And in this case, we're not looking for tiny foci, single voxels with increased activity. We're looking for more regional abnormalities. To classify a scan as positive, there needs to be increased neocortical activity in the posterolateral temporal cortex, occipital or parietal precuneus regions in either hemisphere. And if you see a positive scan, this corresponds to widely distributed tau neuropathology based on autopsy studies used in the clinical trials. A negative scan is either no increased neocortical activity or increased neocortical activity isolated to the mesial temporal, anterolateral temporal, and or frontal regions. So when you're interpreting fluortaucipir PET, do keep in mind of off-target binding to neuromelanin that can occur in the substantia nigra, retinal pigment epithelium, basal ganglia, sinuses, the pituitary, choroid plexus, the meninges, and the skull. So if you're looking at these visually or using quantitative programs, you need to be aware of these areas of uptake that do not contribute to classifying a scan as positive. The reference region is the cerebellar cortex or cerebellar crew, corresponding to the mid portion of the cerebellar gray matter. This minimizes spill-in from the occipital lobe if it's positive, and it can avoid off-target binding in superior parts of the cerebellar vermis. In terms of quantifying tau positivity, there's really not a clinical definition that's agreed upon. Many research studies use quantitative measures for tau, but it's not as advanced as amyloid. And so right now, we can't really recommend quantitative assessment beyond what I showed you for using the cerebellar reference for the clinical read. And some examples of what have been used for tau positivity are a temporal meta-region or a combination of temporal regions that include the interrhinal, fusiform, and inferior middle temporal cortices, as well as the amygdala and the parahippocampus. And this may be more specific to Alzheimer's disease than using intrarhinal or transinterrhinal cortex alone. So we'll stop here. Here's another polling question for you. Please take the time to answer it. So when a scan is positive for tau, again, like amyloid, this is a pathological biomarker for tau deposition. And as we discussed earlier, tau pathology does have a much stronger temporal correlation with neuronal injury and cognitive impairment than amyloid PET. And fluortaucipir, as well as other investigational tau ligands, typically bind to the form of tau that occurs in Alzheimer's disease, but not other forms of tau that can occur in some forms of frontotemporal dementia and other neurodegenerative diseases that are less common. So there are many forms of tau. The flortaucipir, though, is really best suited for Alzheimer's disease and doesn't explore other forms of tau that can occur in other neurodegenerative diseases. And while tau is more closely related to cognitive impairment than amyloid, again, we aren't making a diagnosis of Alzheimer's dementia with imaging alone. In the entire clinical context, the combination of amyloid and tau can be very useful for making the diagnosis, but imaging alone does not mean a patient has dementia. So a positive tau scan does support the diagnosis of Alzheimer's disease in the setting of cognitive impairment, but a negative scan doesn't fully exclude uh, some pathologic deposition of tau, including enough tau for the diagnosis of Alzheimer's disease on autopsy. And so there's interest in improving the sensitivity for these low levels of tau. And that's an area of active research. Here's an example of a negative fluorotaucipir PET scan. We can see in these images that on the upper left, the cerebellar ROI is defined, but we really don't see increased cortical activity anywhere in the brain. We do see a little bit of activity in the basal ganglia and choroid plexus, which exceed the 1.65-fold threshold, but these do not count towards positivity. In contrast, here is a clearly positive case. On the left, we see our cerebellar region of interest. And then in the cerebral cortex, we can see in the temporal, occipital, and parietal cortex increased activity above the threshold shown in color. So this is a clearly positive case. And one of the reasons this is very important is there's emerging data that shows that knowing a patient's tau status has very important prognostic implications. So in this study published in 2022 in Nature Medicine, patients without cognitive impairment were evaluated and classified based on their amyloid and tau status measured with PET. So on the left, we have the likelihood of progression to mild cognitive impairment, where patients who were amyloid and tau negative did have the least amount of progression. But those who were amyloid positive and tau negative also had relatively little progression, although more than the amyloid and tau negative. You can see that those who were amyloid positive and tau positive had a much greater rate of progression to mild cognitive impairment over the 6-year study. And if we look at progression to all-cause dementia, only the group that had a positive amyloid scan as well as a positive tau scan for neocortical spread of tau had substantial progression to dementia over 6 years. And so you can see how knowing a patient's tau status is very important in terms of prognosis. This may become an important part of selecting patients for anti-amyloid and future Alzheimer's disease therapies. So here are some resources available to you from the Society of Nuclear Medicine and Molecular Imaging. These are some general information about amyloid, as well as an amyloid imaging library that allows you to go through DICOM amyloid PET cases, make your own mind up, and then get the correct answer. And again, here are the link to reader training courses. If you're going to be reading these, it's very important that you've completed a training course and know the specific criteria to the tracer you're using.
And so let's wrap up our clinical case discussion. I'll remind you, this is the 78-year-old woman that I saw with progressive memory loss, kind of potentially early mild cognitive impairment, but we weren't certain based on the clinical data or the MRI scan. We went ahead with amyloid imaging using florbetaben PET, and here the results are pretty unequivocal. As you've learned from Dr. McConathy's lecture, this is a clearly positive amyloid PET scan with neocortical uptake throughout both hemispheres. The centiloid value in this case was about 105, so a clearly positive test, both by visual interpretation and quantification. And so if the MRI in the clinical scenario was a little bit ambiguous, I think the amyloid PET scan provides definitive evidence of Alzheimer's disease and actually qualifies the patient for diagnosis as a core 1 biomarker. This is a tau PET scan using an experimental radio tracer called PI 2620. So this should not be used for clinical purposes, but was obtained as part of a research study. And what you see here is that there is extension of tau PET signal into posterior lateral temporal cortex in both hemispheres, I would say, but particularly on the right. This is a neurologic orientation. And you can see some of that tau PET uptake also in the parietal cortex on the right in particular. And so this would be a patient with moderate neocortical uptake, meeting the criteria for elevated tau.
Yeah, I was just going to ask. I think that's a great example of using amyloid and tau together. In someone who's nearly 80, if you only had the amyloid scan, and granted, this one is high in terms of the cortical uptake, but given that roughly 50% of people at age 80 are positive on amyloid PET, what are your thoughts if you only had the amyloid?
So, with the new criteria, the amyloid PET in and of itself would be sufficient for diagnosing Alzheimer's disease. I would have high suspicion that Alzheimer's is contributing to the patient's impairment because it was memory and the family history was strong. But you're right. I think the positive predictive value in terms of thinking about whether the amyloid is related to impairment is less clear with amyloid PET alone in older individuals. In your younger patient, it may be more illuminating because the likelihood of being amyloid positive at age 63, if you don't have symptomatic Alzheimer's, is pretty low. But the tau PET here is really helpful because it does demonstrate that there is neocortical uptake. We think that by the time we see this much signal on a PET scan, the patient is probably in more advanced stages. I would say probably Brock 5 or 6 in terms of their tau pathology. And so we know that that is clinically meaningful to angle pathology. And that really solidifies the fact that Alzheimer's disease is very likely a major contributor to this patient's clinical impairment. And so, um, using our biomarkers, we can now, I think, definitively diagnose mild cognitive impairment due to Alzheimer's disease. This patient would be at clinical stage 3 and biological stage C in terms of their moderate tau PET uptake. So the integrated scale would be 3C in this new staging of Alzheimer's disease with the new criteria. And these results had immediate implications for patient management. So we started the patient on donepezil. She was very motivated to engage in some lifestyle changes, including a mind diet, regular physical exercise. We did refer her for a senior driving assessment. She made sure all her advanced directives are in order. We referred her to the Alzheimer's Association for for additional support, and we did refer her to treatment with an anti-amyloid monoclonal antibody. So she meets the criteria clinically uh, and in terms of biomarker support, and she's currently considering whether she's interested in one of these new anti-amyloid monoclonal antibodies. So definitely having the PET scans helped us reach a definitive diagnosis and triggered some very clear management changes.
So coming back to the second case, this is a 63-year-old man who originally presented with some mild cognitive impairment, and now he's experienced progressive decline with a diagnosis of early dementia since his last visit. He's had a substantial decline in his ABC dementia score, as well as his general activities of daily living score, as shown here, 26 to 20 for the ABC, 24 to 15 for the GADL. And because of this, his family, as well as the patient, are interested in therapeutic options. And so in the area of anti-amyloid therapy, a key question is does he have Alzheimer's disease, and is he a candidate for an anti-amyloid antibody? So here are the results from the patient's amyloid PET performed to determine if he was a candidate for therapy. You can see that there's loss of gray white matter differentiation throughout the cerebral cortex, indicating abnormal amyloid in the cortex. And importantly, there's normal gray white differentiation in the cerebellum, which we use as our visual reference for determining whether or not there's loss of cerebral gray white matter differentiation with the tracer florbetapir. So, another polling question for you. Consider this 63-year-old man with progressive cognitive impairment Based on his clinical presentation and the available imaging, what is the most likely diagnosis now? So at this point, we can diagnose this patient with Alzheimer's disease. His progressive cognitive impairment, along with a positive amyloid PET scan, um, really support this diagnosis. And this is sufficient to proceed with anti amyloid therapy, assuming the other eligibility criteria are met. So this patient presented after 18 months of anti amyloid therapy. And we can see in these images that there is better gray white differentiation throughout the cerebral cortex. And as an imager, this is actually when this patient came to my attention. I was reading the scan de novo and was kind of back and forth as to whether there was a little loss of gray white differentiation or was this a clearly negative study. And as I looked back at his other imaging, looking for an MRI, I saw he had a prior amyloid PET scan. So I think visually we can see there's been definite clearance of amyloid from the cerebral cortex, and you can see better gray white differentiation on the selected images labeled as after therapy compared to before therapy. Whereas in the cerebellum, there was good gray white differentiation before therapy, which is maintained. And so visually, it's easy to see there's been clearance, but as discussed earlier, there's uh, the potential to use this to determine when patients should stop therapy. That's something that I think still needs to be worked out, but it's an area of active investigation and interest. And one of the tools for measuring clearance are SUV ratios or centiloids. And here we're showing graphically in blue decrease between the uh, after therapy, with the SUVR decreasing by about 70%. You can see that in this case, the entire cerebellum was used as the reference region. You can see that if we look at the entire cerebellar cortex in this red orange, there's really no change at all, which we would expect. There's not any significant amyloid deposition typically in the cerebellum until very late in the course of Alzheimer's disease. So this quantitative approach is going to be very important if we need to measure the amount of clearance of amyloid from the cortex over the course of therapy. And this may become important for deciding when to suspend or even stop anti amyloid therapies. So we have another question about this patient. Which of the following is the most appropriate conclusion in this patient who's been treated with anti amyloid therapy? So the most appropriate conclusion is clearance of cortical amyloid, which we saw both visually as well as using SUVR changes. Um, Clinically significant response is really based on how the patient is doing and is a clinical and cognitive measure. Patients can have substantial clearance of cortical amyloid and not have a clinical benefit. So we can't judge the clinical response based on imaging alone. Amyloid related imaging abnormalities, or ARIA, edema, or hemorrhage, are evaluated with MRI. And this is a very important component of the imaging follow up and qualification of patients for anti amyloid therapy, but we cannot assess it with PET. And in terms of artifact and SUVR calculation due to atrophy, that is a reasonable thing to consider. However, both the visual and the quantitative assessment really showed clearance. And while I didn't show you this, we can also perform volumetric analysis of the patient's MRI. And in this case, the degree of atrophy was only a couple of percent. So both with the data presented as well as additional information from MR, we can exclude that choice. So in summary, I'd like to give you some key takeaways from this presentation. Amyloid and tau PET can be used to diagnose and stage mild cognitive impairment and dementia due to Alzheimer's disease. And with the advent of FDA-approved disease-modifying therapies for Alzheimer's disease, the landscape of neuroimaging for Alzheimer's disease with PET is changing. Currently, we're using amyloid PET as a key measure to identify patients with abnormal amyloid neurocortex, which is necessary to qualify them for anti-amyloid therapies. Amyloid PET may be used to decide when to stop or even suspend anti-amyloid therapies, although this is something that is an evolution both clinically and in the realm of research. And as Dr. Rabinovici presented and data is showing, tau PET may be an important measure for deciding who should receive anti-amyloid therapy based on their likelihood of benefiting. So that concludes our presentation. You can visit us at peerreview.com/AD-PET24. Be sure to complete and submit your post-test and evaluation to receive CME credit. You can download the slides and practice aids. You can also watch for an online activity in the coming weeks and request a live workshop at your regional radiology or nuclear medicine society meeting. So again, thank you for joining us. I hope you found this informative, and it's an exciting era. I look forward to future developments.